Well, welcome to Season 2, Episode 12. We're going to talk about restoring endodontically treated teeth, and the article that we're going to be featuring is an article that we published in 2017 in the Journal of Operative Dentistry, and it's called The Wallpapering Technique by Simone Deliperi, David Alleman, and Dave Rudo. So what is the wallpapering technique? Well, the name actually came from our good friend and partner, Wendell Robertson. And Wendell Robertson has a very creative mind. He invented the term biobase, many other clever sayings. But wallpapering was when we were learning the ribbon technique, or I was teaching the ribbon technique to him, and then he went to Sardinia and had some advanced courses with Simone Deliperi on using ribbon in endodontically treated teeth. It just appeared to him that wherever he put it, it was like you're putting wallpaper on a wall. Well, for the younger listeners who don't even know what wallpaper is, in the old days, if you wanted to change a wall's color, or more particularly put a pattern on a wall, then papers that were about this wide were created, and then you would put a sticky material called wallpaper paste on the back of the wallpaper, or in advanced situations, and this was bringing back 1975, the first year of dental school. Linda and I, in our first apartment in San Francisco, wallpapered our apartment with some pretty cool looking printed papers. They were pasted, so you just had to wet it. You didn't have to mix the wallpaper paste, but I digress. But you can look that up, wallpapering in the old days. But the idea is that when we started to understand what ribbon did, that started in a few papers. I just happen to have a few collections of some of the early papers. The very first paper that really had to do with using ribbon in a stress-relieving situation, which is the purpose of the wallpapering, but also the idea of ribbon stopping fracture. That's also integrated into the wallpaper technique. But this paper by Belli that was published in 2006, and this paper published the next year in 2007 by Belli and her team, both showed that placing ribbon on an axial wall or a pulpal floor. The first paper was the pulpal floor. The second paper was the axial wall. So I guess technically if you're going to wallpaper, you'd have to put it on the wall. But the first one was on the floor, so maybe we should Wendell could have called it the carpeting technique. But the combination of pulpal floor and axial wall that surrounds the pulp, these are the areas where the wallpapering technique or the placement of the fiber protects the pulp from having a weak hybrid layer or a weak seal. And so when we started to implement that in the year 2006 for that purpose, we had already started to implement placing of fiber underneath a restoration to prevent a fracture into the dentin replacement. And that was based on a paper by Willem Fennis published in 2004. That was a year after we started teaching 6 lessons. So in the 6 lessons, the idea of a failsafe or a secure situation where if you had a fracture of your enamel replacement, by placing ribbon underneath, Fennis showed that it would not fracture into the area close to the pulp. But then 2 years later, 2006, when it showed that it actually made what was called a secure bond, the secure bond idea had been validated in 2003. And the secure bond was theorized first by Evo Krejci in 2000 in a paper published in PPAD. And Krejci was trying to get his mind wrapped around different approaches to adhesive dentistry. And 2 of the approaches, first he called a total bond approach and a secure bond approach. And then he talked about a separate bond approach. Well, these approaches that are not connecting the tooth, like a bonded amalgam would be an example of a separate bond, then that approach doesn't really mimic a tooth very well. And so we call that a non-biomimetic adhesive approach, where you're sealing the dentin, but you're not connecting the sealed dentin to the restoration. But the other 2 approaches, a total bond or a secure bond strategy. The total bond, the idea is you're trying to have the same bond throughout the tooth. And they were thinking that that would be ideal, but actually the tooth itself has different levels of connectivity in the natural state. For example, enamel is connected to itself at around 11 to 30 megapascals, depending on the portion of the enamel that you're trying to pull apart. That's related to the way the enamel develops. When the ameloblasts do their weaving and dancing as they form enamel, quite extravagant, very beautiful to think about how these enamels are formed. But that strength of 30 max is a lot less than the actual cohesive strength of the DEJ, for example, at around 50. Or other parts of Dentin have a cohesive strength that are way above 30 megapascals. But if we, in a biomimetic approach, say if we can get our restoration connected to the tooth at the same strength that enamel is connected to itself, that's kind of like the bottom line. If you got something higher, boy, that would be great. But the connection of the tooth to the material is dependent on many factors. And the factors are, in the Dentin, how much hydroxyapatite you're trying to bond to. And if you're trying to bond a material that has a high bondability, but you have a substrate that takes time for the bond to mature, then that is called a difference in the hierarchies or the levels of the hierarchy of bondability. Of course, this is a proprietary concept that I came up with to help me understand why certain restorations fail in certain places and other restorations fail in different places. And it turned out that the failures are always low in the tooth or high in the tooth. The high failures are fractures in the enamel. The low failures are fractures in the dentin. The fractures that are lower and closer to the pulp are the ones that are the most biologically threatening and detrimental. And so a biologic failure that allows infection of the pulp kills the pulp, but a clinical failure that would just be the enamel chipping would be very repairable and not biologically detrimental to the health of the vital pulp. So all of these concepts, as I was trying to figure out how to make an ideal restoration, in my mind came to the conclusion that Evo Krejci's 4 types of bonding strategy, there was one that was really superior, and that was a secure bond strategy where certain areas of the restoration would have a little lower cohesive strength. So in the case of failure of the enamel, it would not go deeper, closer to the pulp. And the idea that you stayed bonded around the pulp and never violated that, even if you had over time some type of fracture into the enamel and or the dentin replacement, that was a very appealing concept, and it was proven in 2003 and 2004 in 2 papers, one from TMDU University under the auspices of Jayasuriya, was the lead researcher. Patricia Pereira was also on that team, Toru Nikaido, also Junji Tagami. But they showed that there was a way to construct a restoration that if you had the hybrid layer in place and then you put a resin coating, and the resin coating that they used was a microfilled flowable, then if you cemented with some type of composite restoration that wasn't exactly the same as the microfilled flowable, and that usually has some kind of hybrid characteristic or even a microhybrid characteristic, the difference between the microfilled composite and a microhybrid composite or a microfilled composite and a hybrid composite turned out that if you took the restoration apart and tried to pull off through some type of tensile or even shear stressing, that you would always leave the dentin bonding system, that immediate dentin sealing, covered, and that resin coating that was covering it never failed. And so that was called a secure bond strategy. Again, 3 years previous by Evo Krejci, but Evo Krejci didn't continue to research and think about how that might be achieved. It's first achieved in 2003 by Pramali Jayasuriya, Patricia Pereira, and the other researchers at TMDU. So that's the first idea, that you can do something in a restoration that if it fails in a way that protects the pulp, or it secures, or it has a safe fail, a fail-safe characteristic. And so again, after 2003, then we had 2004 from Fennis showing that Ribond had another fail-safe characteristic, but this time it was tested not near the pulp, but underneath the enamel, kind of mimicking the DEJ. DEJ usually stops cracks or diverts cracks, and most cracks, the vast majority, do not go into dentin. And so this mimicking of the DEJ by the Ribond was actually the first protocol that I started to use and teach. And this protocol was an addition to the protocols that I'd used for since 1998 to 2003 as kind of the beta testing for what we called advanced adhesive dentistry that now we call biomimetic restorative dentistry. But now we had two ways to have these fail-safe mechanisms. We had one close to the pulp with this resin coating, a microfilled, and then we had this Ribond fiber underneath the enamel. And so the design of a very deep preparation could use both of these, protecting the hybrid layer and protecting a more catastrophic failure from the top. So these two strategies we started to teach together 2004. And then 2006 came along and it explained another concept, combined resin coating and Ribond placement. And that was Sema Belli's 2006 paper, followed up in 2007. Later experimented with and reproduced at the University of Toronto by Elma Wafe. Another experiment by Osel and his team in Istanbul. All gave the validity to these fiber nets or this fiber placement working in a way that it secured the bond, made a fail-safe situation in the restoration, and the stress relief that was shown actually totally demonstrated the next year, 2008, by Erkut in endodontically treated teeth. All of these things coming together in these years, and of course that's about 8 years, 2000 and 2008, but we're teaching the 6 lessons from 2003 to 2008. But the idea that eventually it came together in a strategy for restoring endodontically treated teeth, both based on a fail-safe concept, a secure bond concept, and these working together allowed us to guarantee that the top of the tooth in an endodontically treated tooth was never going to fail. Unfortunately, research, and we knew this going in, on the difference between a vital tooth and a non-vital tooth showed us that the roots themselves lost 60% of their toughness. They became 60% more brittle after endodontic treatment. And this was the paper that was published in 2007 by Jaya Surya. It had already been talked about in the endodontic literature, but the in vitro hydrated test that Kishan and Vedantam did versus the non-hydrated endodontically treated teeth showed us that you lose 300%, or you should say you decrease 3 times the ability of the tooth in its roots to not instigate or propagate cracks. So, paper by Sophia Schwartz, published around that same time, documented many 32 cases of root canal treatment, starting the process of crack initiation, crack propagation, and catastrophic failure. Well, all of these mean that if you start to restore an endodontically treated tooth, the dogma of putting a post and a build-up and a full coverage crown, which was what every dental school mostly still teaches today, was being replaced by no posts and an adhesive approach. But the posts that were tested against a Ribond placement in some part of the root canal or in the coronal portion of an endodontically treated molar, that this Ribond was very different from any type of mechanical buildup that was placed. And so Simone Deliperi and I had been using these concepts in endodontically treated teeth since basically 2002, when the first papers from Sema Belli were being published on restoring endodontically treated teeth with this custom-made buildup. It could be called a post, but the idea that Ribond was able to, in these adhesively restored root canal treated teeth, it could absorb the stress of polymerization in this high C factor situation. the ratio of bonded and unbonded surfaces in a pulp chamber is very, very high. And so if we have a stress of over 5 in our C factor calculations, then that's going to decrease the bond strength about 80% if left without a stress reducing strategy. And so the stress reducing strategy that I invented was called decoupling with time. What did that mean? That meant that based on the literature, leaving a hybrid layer to mature in its chemical reaction for a minimum of 5 minutes, an ideal 30 minutes, would allow that hybrid layer in its polymerization reaction to form the strongest hybrid layer possible. If you started to pull or stretch that hybrid layer too soon in that 5 to 30 minutes, then you'd have a decrease of bond strength anywhere from 80% decrease to 70 to 60 to 50 to 30. You get the idea, is that the sooner you start to put stress on the hybrid layer, the more reduction of bond strength, because you're stretching and changing the internal structure of that polymerization of the polymers that are interacting with pulpal fluid and collagen. And the best paper, we talked about this in the earlier lectures, is the Nikolenko 2004 paper, which gives a direct evidence in vitro testing on what it means to have a hierarchy of bondability, what it means to ignore the hierarchy of bondability, and one strategy to improve bond strength next to the pulp by waiting a period of time. In the Nikolenko paper, the time was about 3.5 to 4 minutes. We understand, and now we've been doing this in over 1 million teeth of the doctors that I've trained, that once you do this, the leakage in a deep box or the leakage close to the pulpal floor is eliminated. And that is because the tooth is acting like a tooth. It doesn't have these gaps and cracks next to the pulp. So the pulps don't die from a reinfection or a crack initiation underneath a restoration when we use the 6 lessons approach of deep caries partial removal and cracks partial removal, total removal in the peripheral seal zone, and partial removal to prevent pulp exposures on the axial walls and pulpal floors in these deep lesions. So this wallpapering technique, the paper that we published in 2017, gave a case that's now over 13 years old. The paper, when it was published, we waited 6 years before that case had success for 6 years. So that case now is 14 years old. Simone Deliperi has recalls on that and no breakdown. So here the dogma of putting full coverage on a tooth is disproved. But how does that work and how is it carried out? Well, when you read the wallpapering paper in operative dentistry, you will see it's a very defined protocol. Unless you understand what the pictures and the photos actually represent, and you're going to have to read the paper very carefully or be trained by Simone Deliperi or myself or anybody else who has been immersed in the literature that we've been discussing in this podcast. You can see that you have all of the concepts of lesson 1, dealing with caries, lesson 2, dealing with cracks, lesson 3 with immediate dentin sealing. Obviously, the dentin sealing has to be used a particular protocol with particular bonding system. This bonding system that Simone used in this case was a 2-step total etch dental bonding system called Allbond 3. So the condition of the smear layer was not with air abrasion, but it was with a total etch. And then the bonding system, it's the best one bottle bonding system. PQ1 from Oper Dent would be the other one that would be similar. It had a thick adhesive layer that was also the priming. And these one bottle systems, we know that has a negative effect, particularly if the adhesive is very thin. In this situation, the adhesive has about an 80 micron thickness, similar to the thickness of bottle 2 of the 3-step total etch approach of Optibond FL. And so Simone's been using this successfully. We know that the bond strengths will be 30 or greater. And once the immediate dentin sealing is placed, then the next step would be the resin coating, lesson 3. This resin coating in that paper that Simone wrote most of the text was a follow-up on his 2002 paper. So 15 years earlier, Simone had written the paper with Dave Bardwell in the Journal of American Dental Association. And the resin coating at that time, he put it at 1 millimeter. I've always believed that a 0.5 millimeter is more ideal. My second mentor, Gary Unterbrink, always said, think of the flowable composite as a filled adhesive. In other words, if you have a 2-bottle system like Optibond FL or SE Bond or Protect Bond, the priming bottle is different than the bonding bottle, and the different molecules allow the primer to be effective, and different hydrophobic monomers allow the adhesive layer to get a uninhibited thickness of monomers, so the air inhibition does not stop the polymerization of a thin adhesive layer. And so when you put the light on an adhesive that has a thickness that's substantial, that would be the way to ensure that the transudation or the water train will be stopped coming from a vital pulp. Of course, on a non-vital tooth like this wallpapering paper is, you're not worrying about transudation. You're just worrying about air inhibition and creating this fail-safe, secure bond strategy using the resin coating, as the 2003 Jayasuriya paper proved. And so, as Simone in the 2002 paper, again followed up in 2017 paper with the same bonding system, now we have a resin coating of 1 millimeter on top of a good bonding system. This All Bond 3, very good bonding system. We have clinical proof of that. But now, once that's happening, what do we do to make sure that those bonds have that 5 to 30 minute period where they can mature to the fullest? Well, Erkut papers showed us that if we put Ribond on these walls of an endodontically treated tooth, then the Ribond, if there's any stress of polymerization in that high C factor preparation, the Ribond will separate a little bit, and that is a stress relief mechanism. There's still a connection with the resin coating and the composite that's next to the resin coating. With that Ribond, that connection is only about half of what it would be if it was just composite connected to itself. In other words, the cohesive strength of composite connected to itself is about 40 megapascals. If you have Ribond in between this, then you have little islands and projections of composite that are connected to each other, but you have other areas that are the Ribond fibers. So if you pulled it apart, it would pull apart at about 20 megapascals. Now that's only compared to enamel, not as strong as enamel, it's not as strong as dentin, but the idea is we're putting this in as this fail-safe strategy. You're building that in the event that you had a fracture of dentin replacement, an endodontically treated tooth, you would still seal the pulp chamber and the canals would not become reinfected. So that was the strategy. We've been doing that successfully for 20 years, and we've had no failures in the coronal portion of a endodontically treated tooth. I have personally had 3 failures in the root system of an endodontically treated tooth. My son Davey has had a couple in 6 years. But again, these are in very thin roots, endodontically treated teeth. The failures are not in the coronal portion, but in the root. When that fractures, then you do have a catastrophic failure. But this is out of hundreds of teeth that we've treated. And so the percentage of failures in endodontically treated teeth are less than 1%. We hope that that stays lower than any percentage of implant failures. Time will tell. But the decision of the patient is try to save an endodontically treated tooth. Then the strategy should be we want to make sure that that tooth does not get reinfected from the coronal restorative part of the tooth. The leakage, if it goes into the root, then the root can become reinfected. And of course, if there's any fractures that aren't diagnosed and removed, then those fractures will continue to propagate, and then a root fracture and potential catastrophic failures could be in the future. So when we talk about endodontically treated teeth in the 6 lessons approach, we actually have a different designation. We don't call it part of the 6 lessons, we call it lesson 7. It's kind of like a caveat saying, we're going to use all of the concepts that you've learned in the 6 lessons, lessons 1 through 6. On vital teeth, we pretty much guarantee, a tooth that's not going to have a pulp die, a tooth that's not going to have a catastrophic failure. There will be some repair of enamel replacements, onlays, ceramic onlays that are too thin, for example, or composite that wears too much over 20 years. Then we can use some repair techniques on vital teeth, and these usually mean that there will never have to be a revisiting of the hybrid layer in these vital teeth. But in an endodontically treated tooth, we have this problem of the non-hydrated roots that become brittle. And so we say to the patient that this tooth will be adhesively rebonded, but we can't regenerate the hydrating portion of the tooth, which really gives it its toughness so that it doesn't act like a brittle material. Although technically enamel and hydrated dentin are brittle, they're not as brittle as unhydrated dentin. And that's the conclusion of the Vedantam and Kishan paper that we referred to earlier in this lecture. That pretty much finishes up season 2. We look forward to doing some more next year. Hopefully things go well for all of you and you're able to get the training and the mentoring and making the advances in adhesive dentistry that can be very satisfying, rewarding to both you and your patients to get bonded, stay bonded, and conserve as much of God's gift to you in the way of teeth as possible. So until next time, we will say, get bonded and stay bonded.